is to pay close attention to the behavioral health system of care, and not only how it may interact well or not interact well between different types of services, but how in the system of care, both medical and social determinants of health, how does behavioral health kind of play a role, and do people have opportunities to access the different treatment programs that we may have available in the Mat-Su area. So my role is to make grants with kind of that goal in mind of kind of gluing the system together and helping it to work better for patients instead of having it work best for payment. And as you'll kind of hear later on in the presentation, some of the things that we do through the HUMS program that really help to make it work. There are obviously other focus areas in the foundation: healthy aging, healthy families, healthy futures, healthy foundations. So we really grant a lot of to a lot of 501c3 nonprofits in those particular areas, because we know that with helping the high utilizers become less dependent on the emergency department for non-emergent care, that they also need food stability, they need housing stability, they need a variety of the other programs that we help to sponsor here in the Mat-Su. Before I get too far down the road with HUMS, I'd like to back up just a second to ensure that everybody on the call is well oriented to kind of the place and the purpose and the origin, I guess, of the Mat-Su Health Foundation. So we're doing business as the Mat-Su Health Foundation, but we are the original Valley Hospital Association, the nonprofit hospital established back in the 1930s. And the hospital was sold in 2010, and we remained connected to a for-profit hospital with this kind of joint venture. And we then have the benefit and the privilege then to be able to use some of the profits annually from the hospital to reinvest in the form of grants back into health and wellness in our community. So a lot of the 100% of our spending, of course, comes from the hospital. So we don't have to raise funds and things like that to add to our foundation and support that work. So in doing so, the mission and the vision of the Mat-Su Health Foundation is really centered on the goal of this jurisdiction becoming the healthiest borough in the United States. And really the vision of the foundation is that anybody who lives in this particular area has access and has the opportunity to live a healthy lifestyle, no matter what their position is in life, socioeconomically, racially, no matter what, that everybody is guaranteed to have that. So we keep that mission and that vision at the forefront as we make particular grants that help to increase kind of our adherence or our progress toward those goals. So we also work then at the systems level, which is really trying to work closely with the community and to listen to the community and to discover what the needs are in our community by having a very sensitive ear toward those things. We also do a lot of work that is research-based, and we commission a lot of research projects, which is really how we discovered that a high utilizer program was going to be effective in our community. And we practice at least data-informed, but a lot of times data-driven decision-making, that we don't really embark upon large projects like HUMS unless we really have good solid data in which to back the spending of those grants on that particular program. So really then, how does HUMS get created out of the position that the Health Foundation finds itself in the community, and through its research and through listening to the community, how does HUMS get born? So in 2013, we embarked upon a community health needs assessment, which according to IRS rules for 501c3, we have to conduct that community health needs assessment every 3 years. As a matter of fact, we're embarking upon one this year because one is due in that third year now. So in 2013, we asked residents of Mat-Su what they thought were some of the biggest challenges we were facing in Mat-Su when it came to health, when it came to, the ability to access health programs. And there were 5 major findings in that report. 3 of the 5 findings showed that the biggest challenges that we faced were in the area of behavioral health in Mat-Su. Alcoholism, depression, suicide, drug use, things like that. That was before kind of that spike in heroin use that we experienced in 2015, 2016. So that really prompted us then, hearing what the community's concerns were, it prompted us to do a comprehensive behavioral health scan of the emergency system in Mat-Su. And where do people that are suffering behavioral health problems end up as a first contact or a first walking through that first door to get help? And what was that system like? The second part of the environmental scan for behavioral health was to really map out the entire treatment system and the continuity of that, and to really compare it to the SAMHSA model of a good and solid behavioral health system that helped to provide all of the supports that people need in going through trying to recover from mental health conditions and also substance use disorder conditions. The third prong of the behavioral health scan was really to dissect the system of prevention. How do we embark upon drug and alcohol prevention at a very early age? How do we address suicidality very early on? What conditions lend themselves to some of those conditions? So the scan for the emergency system itself showed that the emergency department, the 3 law enforcement agencies that we have in the Valley, our borough emergency medical services, EMS, and the jail were really providing most of the emergent behavioral health interventions in Mat-Su. They weren't clinicians, they weren't peers, they were people whose main jobs were medical, life-saving services, or public safety, law enforcement services for the most part, and then the correctional system itself. That's where people were getting the help that they needed. And those are the agencies that's not their primary focus to offer those services. It was also found in the report that there were over 400 Mat-Su residents who used the emergency department 5 or more times per year, totaling an average of about $14,000 per individual in annual emergency department medical costs. And obviously it was much higher for those that used the emergency department over that 5 times. We have very super utilizers, ultra utilizers. We have a whole list of those, and those expenses largely being supported through Medicaid budget or charity care or perhaps private insurance. The Palmer, Alaska State Trooper Detachment responded to 852 behavioral health calls in 2013 alone. And during that same year, emergency medical services responded separately to 432 behavioral health calls in 2013. Many of those patients ended up in the emergency department or our local Mat-Su pretrial jail. Along with the findings of the report, then we have had some very specific recommendations that were born out of that report. And that was to provide more training for law enforcement, EMS, in behavioral health and how to interact and determine and separate out aggressive, violent behavior from somebody on the street and try to understand more deeply maybe the causes of those behaviors and be able to maybe respond to those behaviors in a way that's better for the patient. And that's called the Crisis Intervention Team Training Academy that we try to hold annually here in Mat-Su for first responders. Another recommendation was to establish a crisis stabilization center, a crisis call center, behavioral health urgent care, and mobile crisis teams to respond to those. And many of you have probably heard about the Crisis Now project that's being sponsored by the Mental Health Trust Mat-Su has one of the 3 major projects in that particular service area, and we're very close to getting some of those systems in place. We developed the HUMS then based on the report and based on the recommendations in that report and that particular data set. We formed a crisis intervention team coalition of lots of community champions whose participation and their motivation for improving the system was really unsurpassed by any other project that I've been involved in. Dr. Zink was one of the very early champions in the project, and then has passed that on to Tom. As a result, the Alaska State Troopers have had at least 3 or 4 generations of turnover in leadership since 2013, and they have remained a very consistent partner in finding solutions for behavioral health calls. So they've been very active in the Crisis Intervention Team Coalition as well. So we granted we made a large grant for the High Utilizer Program based on that interest from the CIT Coalition, but also based in the data, which was also then borne out in that original Community Health Needs Assessment from 2013. We have used and deployed a community health worker model to this project because we weren't really completely sure what kind of patients we would be encountering. Would they be high medical complexity? Would they be high medical complexity along with a strong behavioral health component and maybe an undiagnosed condition? But we really needed to be open to what the patients were bringing us so that we could respond in kind then to what services they might need. We hired at the time, nobody really had the expertise to be able to put together such a program. So we did hire a ER physician from Everett, Washington, whose side job, if you will, was to establish these care coordination programs in different communities, like in Olympia, Washington, Spokane, Washington, and other locations that Dr. Enrique Inguadanos had been helping. So we contracted with his agency and worked with him for well over 2 years to actually build and implement in Mat-Su this high utilizer program, this team of community health workers with the medical oversight of Dr. Quimby and Dr. Zink at the time, to really shepherd through and push through addressing the needs of the high utilizers that were identified through our EDIE system, Emergency Department Information Exchange software that we're using at the hospital. So HUMS then provides that connectivity to specialty care, to primary care, to behavioral health care, to the social determinants of health, to all of the basic foundations that people need to be able to even get into the space where they're able to address their own healthcare needs. Transportation, food, clothing, appointments for assessments, things like that. And I know that Aaron will get more deeply into those things here in a moment. We also formed a multidisciplinary team, an MDT, which is a pretty common acronym, of course, in behavioral health, but it's also pretty common in physical health too, in that we formed a local MDT, which at the permission of the patient through a release of information, we were able to monthly come together and discuss the really difficult, complex cases that the HUMS program was finding. And it was a chance for different professionals from the different sectors of services, mental health, substance abuse, emergency department care, the court system, Department of Corrections, FQHC, behavioral health entities, the emergency department physicians group, all could get together monthly and just talk openly about their experience perhaps with this patient, but also what referrals could be made and who at the table could step up and step forward to providing service through the HUMS program that might coordinate that care. So that's been very valuable, and we're now connecting our MDT work more broadly to look at and support that Crisis Now project that I mentioned a little bit earlier. So I'm going to pause right there, and if there are any questions you may have, if you'd like to ask them now, that might be okay, but if you want to hold them later, but I'll then, if there aren't any questions, I'll pass it over to Quimby.
Okay, thank you, Ray. Let's go ahead and hear from Dr. Quimby, and we'll bring him in.
Sure. Good morning, everyone. Thank you so much for inviting me to this forum. Talking about the HUMS programs, one of my favorite things. It's a really great program that, as I'll explain, kind of through the unique lens I have of actually working in the emergency department, really get to see firsthand how that's been a benefit to the community. But yeah, by way of introduction, I'm a full-time emergency physician. I work at Matson Regional Medical Center, and currently I'm the medical director of the emergency department, as well as the medical director of the HUMS program. And it probably is helpful to kind of explain some of the history here. I have a colleague and friend that some of you might have heard of. Her name's Ann Zink, and she was previously the medical director of the emergency department, as well as kind of setting up this HUMS program. And she decided to go on a year-long sabbatical around the world a number of years ago and approached me and said, I'd like you to just hold my position while I'm gone for a year. And I was very reluctant to do this. And then she never came back to the position. So I've been doing it ever since. And they were big shoes to fill. And actually, I think it was like the day before she left on her trip, she said, oh, by the way, in addition to the medical director of the hospital, I need you to do this HUMS program. She hadn't told me about it. I didn't know about it. And I think my initial reaction was kind of telling. I initially was very skeptical. So I just to explain, those of us who work in the emergency department have very much internalized this idea that there are going to be people who will come sometimes hundreds of times to the emergency department in a year. And we know these people very well on a first name basis. We'll start our charts with, this is so-and-so who is well known to our emergency department. And most of us have internalized that work in emergency medicine as either physicians or, advanced practice providers or nurses, that there's just nothing we can do about this. And this is part of the practice of emergency medicine. And we just, we know here comes so-and-so. This is the third time he's rode in on the ambulance today. So when this idea of this program was pitched to me, I have to admit, I was very skeptical. I did not think that there was much we could do about these patients. Traditionally, we would develop a care plan book, and the medical director would write down some care plan, and occasionally you'd pull it off the shelf. And it was pretty ineffective and often didn't make a difference in the fact that people were coming in a lot. So I was very skeptical of this, but since Ann asked me to do it, we went ahead and started with the program and met Ray and some of those others involved early on. And what I can say is, thankfully, much to my surprise, that this program did have a big impact. And for the first time in my career and my colleagues, were actually able to, not with all of these patients, but with many of them, address some of the needs that were causing them to come to the emergency department very frequently. And that's really what we found out, is that someone showing up to the emergency department many, many times in a year is a representation of some failure somewhere in our system. Our emergency departments really are a net to catch people when everything else has failed, or in some cases it's a very acute situation and we're definitely the right place. But for these people coming a lot, it just represents somehow they're not getting their needs met anywhere else in the system, and so they have to come see us. And sometimes we're not really a great fit for the problems that they have. And it does get frustrating for patients, and it gets frustrating for emergency department staff to kind of continue to just get nowhere and go around and around and around in circles. So what we found early on with the program is that these visits do represent some failure somewhere in the system. And what we next found was that these different failures can take a lot of different forms. People all along have wanted to know the percentage of people in our program who are high utilizers that are behavioral health or, have mental health issues. And they want to know those who are coming in because of chronic illness. And we can't give you that number because it's really hard to delineate that. In fact, there's just tremendous overlap. There are some who definitely are just pure behavioral health. We have, one of our most challenging clients right now is someone who is young, who has a diagnosis of, the old diagnosis is borderline personality. I'm not sure what the correct term is nowadays, but they really don't have medical problems, and it is all behavioral health, and they're coming. And so there's a few of these people that fit purely in that bucket. And we've got a couple, people over here that are just very complex end of life medical care, but usually even those patients have anxiety tied into it that often, we've had people who have extensive cardiac history that then develop an anxiety component, who then are coming in multiple times a week because they're concerned they're having another heart attack, and they are over and over and over again. And so it's very difficult to disentangle this idea of a chronic medical problem and a mental health problem. And oftentimes we found that they're very intertwined. And so what we do have, a percentage of people, as I mentioned, that are, very much more probably in the mental health issues and their behavioral issues that they're showing up. And there are some that are, they've got really bad congestive heart failure, or they have end stage liver disease and they're coming in to get their ascites from their abdomen drained, weekly because they haven't been able to figure out how to do it as an outpatient. We've had people who had pancreatitis over and over again and weren't able to get connected with a gastroenterologist because they didn't understand the system and didn't have transportation to get there. So there is this wide array. And I think the secret to the success of this program is a couple things. One, we do have these community health workers, and we've empowered them to look at each case as an individual situation, and then to figure out what the needs of that specific individual is and create a customized care plan to try to meet those needs. It's really hard to come up with a boilerplate template for here's what to do with every patient. And so I think allowing that autonomy and training those individuals to be able to address and understand solutions to a wide array of medical and behavioral health problems has been really key to the success of the program. As Ray mentioned, these care plans, and that's part of my role as medical director, is to vet those, to make sure that they are medically appropriate. And then that information is available through this electronic system that we have that I'm terrible with acronyms. It's the EDIE system, but I think it's now just Collective Medical. And this feeds into all of the other major hospitals, I think with the exception still of A&MC and the Anchorage Bowl. And so, as well as a bunch of places nationally. So my colleagues at, say, Providence Hospital in Anchorage, when some of these patients show up, they can see these care plans that have been created by the community health workers that I vetted. And then that's extremely helpful for them in some of these situations to understand the background with some of these patients and to better serve them. So I think the other thing that has been really helpful, in addition to being able to have that autonomy to create custom plans to meet the needs of these people, is to then have the resources behind it to actually accomplish some of these goals. So what I mean by that is, for years I've worked in hospitals where we've had an emergency department social worker. They'll come down, they'll talk with the patient, they can help make some phone calls and connect people to resources. They might be able to get the patient a cab voucher, but they've never been able to, get them rides to their, specialist appointment. They've never been able to usually call and make those appointments. They've certainly never been able to get them, a night in a hotel or get them a cell phone. And those kind of things have been, I think, really, really meaningful, and have bridged that gap between traditionally like hospital-based social work and then community resources. And so I think that's been a big key to the success. Ray mentioned the multidisciplinary team. That's also been very, very helpful. We built that up to become quite robust now that there's many community partners that we find are interfacing with a lot of mutual clients. And so bringing all those people together, getting input from everyone, the prison, the housing people, the substance use people, or the substance use treatment people, and then to talk about those clients and get all of that information in one place to make a plan has been really beneficial as well. So I'm happy to sit here now and tell you as a skeptic that after having been a part of this program for 4 years now, we've very much been able to see a benefit to our community, and specifically someone who works in the emergency department. My colleagues and other staff members have been really grateful for this program to see, because it's really hard for us. We get to know these people on a first name basis. It's super frustrating for us, as I mentioned, for them to see them come in over and over again, not be able to meet the needs that they have, and to feel helpless in these situations. And so to finally have a program and a way to actually meet people up with these needs, and for them, in many cases, to stop coming to the emergency department as much. I mean, we've got lots of work to do. We have no problem seeing whoever comes to the door, but it's just not very gratifying to not be able to address someone's problems. And so that's been really meaningful. There's some specific stories. One of the ones that I like to share is that one of this really sad case we had a number of years ago. We had a gentleman who I had known the entire decade I'd been here, who had type 1 diabetes. And unfortunately, he developed, as many people do, type 1 diabetes is a really difficult disease, because all of a sudden you're slapped with a chronic illness that requires a lot of awareness, and you have to be on top of it. And this all happens when you're a teenager, and it's not fair. And a lot of people have a hard time internalizing the fact that they really need to stay on top of this if they want to be their best, healthiest self. And so we do, unfortunately, see a number of these people develop substance use problems to cope with this. And that's a terrible, terrible combination, because then these people aren't taking their insulin. They keep coming in diabetic ketoacidosis, which is a life-threatening condition. They are shortening their life every single time we see them, if they make it through the situation. So this is a gentleman who's coming in critically ill all the time, and DKA about once a week. He got to the point where, I mean, we couldn't even get IVs in him anymore. We were having a hard time putting large central lines in his big vessels in his neck, because we had to do that so many times. And for a while there with the HUMS program, we were able to have quite a bit of success. This gentleman was able to get connected with resources for his substance use, and achieve some sobriety for the first time in his life, had a job. And so that's just kind of one illustration of the successes that we've been able to see. I think one of the weaknesses of the program that we're working on is it is still a voluntary program. A lot of other places like the state of Washington looked at this problem and said, look, we're paying a lot of money through Medicaid. And so if someone's coming to the emergency department, they have to enroll in these high utilizer programs, otherwise their Medicaid is going to get restricted. And so that, I think, forced some engagement for people that might not otherwise engage. We still have voluntary enrollment. And so sometimes people who should be in the program are not, because they choose not to be. And we are working right now. We're really excited to start doing some Medicaid billing. And we've talked repeatedly with people in the state to try to get to a point where this might be something that they would adopt as well, but we're not there yet. So anyways, I'm a huge fan of the HUMS program, really happy to be involved. It's been a great benefit to our community. It's been really helpful for the emergency department. And thank you again for inviting me to present this today.
Great, thank you, Dr. Quimby. And now we'll hear from Aaron Wright. Aaron? Go ahead.
Thank you. Can you hear me all right?
Yes.
Okay. Echo what Dr. Quimby said. Do appreciate the invite to share about HUMS. I would like to give a quick overview for Lynx Resource Center for those of you that aren't familiar with Lynx Resource Center. By 2023, Lynx Resource Center will be serving the Mat-Su area for 30 years. We have 4 programs: a veterans directed care program that allows veterans to stay in their homes longer. We also Lynx started out as a community parent resource center to help individuals with disabilities and individual education plans through the schools. And then we also have an Aging and Disability Resource Center that helps seniors with Medicaid, Medicare, Social Security applications, and pretty much anything you can think of that they're needing. And then, of course, our HUMS program, which we're here to talk about today, helping our high utilizers in the borough. So I do have, for those that are visual, a PowerPoint that I'm going to share. And let me pull that up. Can everybody see that okay?
Yes.
Okay, great. I can't see you, so thank you for telling me that. So I'm going to break down. I'm actually taking our year 3, quarter 4 data to give an overview of some of the data that we have. We just completed our 4th year, but we're still working through that data, and so we're gonna look at year 3 through this PowerPoint. I would like to give a thanks to Strategy Solutions Inc., who is our consulting firm that's been working with our data. Ray worked with them and got them involved back at the beginning in 2018 to be our external evaluator. And so the data that's pulled is through them, and they work with us to gain all of this information. So in the last quarter, the 4th quarter of year 3, you can see that we worked with a median age or average age of 47 years old. 59.5% female, 40% male. We had about 109, 111 people in that 4th quarter that were considered actively enrolled. With disabilities, there was 61%. With no disabilities, there was 38%, excuse me. Behavioral health need, which continues to remain high as well. You see 67% with none. There was 32%. So the behavioral health need continues to be one of the driving forces, that and complex medical needs. And I'm going to share a little bit more about that. Caucasian was the most served at 77.5%. And then you see the other numbers there. Alaska Native 13.5%, Hispanic 3.6%. And we did find that 81% in quarter 4 did have Medicaid. And as Dr. Quimby said, we are actually looking at billing for Medicaid through the 1115 waiver. So we're actually in the process of working through that as well. I would like to add that Strategy Solutions Inc., we use multiple data sources. So Collective Medical, as you heard Dr. Quimby talk about, which comes through the hospital. We're able to do pre-HUMS and post-HUMS baselines. We have it divided out into what we call HUMS 1 and HUMS 2. So you have the less medically fragile people as compared to the more complex medical issues and behavioral issues there. And so we split those groups out. We also use our Salesforce database, which also brings in the demographics, the assessments, correlation between the amount of intervention and ED visits as well. Through the financials that you'll see here in a little while, we pull that through the hospital through de-identifying those who are enrolled, the patients that are enrolled into the HUMS program. And so that's how we're able to pull much of that data. So by quarter 4, we were able to have an overall reduction of 30.2%. You can see emergency department utilization. It continues to decrease with time as they're enrolled. So over a 2-year period, we have a 51% decrease in those that were enrolled over 2 years. And so it definitely, as they stay in the program, it helps them through navigating their medical need or behavioral health issue that they have. Out of those that were enrolled in quarter 4, roughly, as I said, 111 clients and patients, this is what they were reporting to the emergency department for. And again, as you see some of these things, the chest pains, nausea, vomiting, lower back pain, sometimes those symptoms were there, just that they may not have been there, but that's what they reported to be having issues with. And so through those, we were able to work with many of these clients to lower their admissions to the ED with these symptoms that they may or may not have had. I would back up and say we were able to lower this because, and I'm going to talk more about it, through providing transportation to a regular PCP and having regular visits with medical professionals that they need was able to help slow those number of admits down. Something we pull through our database here is our community health workers in the HUMS program provide an assessment. These are some of the areas that the Q4 participants shared that they were having issues with. So as you can see, much of it is not medical. These are daily items, daily needs in life that they're dealing with. Here you have some more of the medical, substance abuse, homelessness, not feeling hopeful, need a primary care provider, as I said earlier, don't have a diploma. These are just some of the items that they're dealing with in their personal life that really has affected them and trickled over into medical issues as well. So, in year 3, Q4, we had about, this is, and I guess I should back up, let me tell you this. For this assessment area, so we had 81 participants currently enrolled in the program during this assessment. And of those, the 25 of the participants had multiple assessments done. And this is where that assessment came from, was through those 81 participants. And the same would be said for the primary diagnosis that we looked at a minute ago for the hospital. That was from those same participants. So in Q4, we spent a little over $3,000, $3,200 roughly, on many of these participants as well. And so by spending a few $1,000s, we were able to save several $100,000 just in one quarter. As we break down the quarters, depending on what quarter it was, I mean, it ranges anywhere from $200,000 up to, if you look at a quarter over an 18-month span, actually split up, it can be up to $1 million. We're on track this year from looking at the numbers to spend anywhere from $80,000 to $100,000 for the entire year, and going to end up being able to save millions for the hospital, and also leave room for those that have true medical emergencies that need to be at the emergency department, that need to be treated. So over the year 3, the total cost savings for participants who visited MSMRMC ED had an overall reduction in ED utilization, and we saved over $4 million. And that is also including the cost to run the HUMS program. So very large savings for them. This is a survey that was done just recently, actually. This just shows you for the participants that have been the participants part of the program, their satisfaction level is extremely high, and has helped them feel supported in their lives, which has reduced the ED visits as well. I'd like to back up and talk a little bit more about these assessment areas. I think this is the bread and butter of the program, because through the 3 community health workers that we have that work with the participants, it's not just the medical issue. We're able to provide transportation, hotels, cell phones, sit and talk with them. It may be that we need to provide a tent because shelters are full. There are no beds. There's no housing currently in the valley. It's difficult to find housing, and it's just a matter of getting them a tent and to help them feel warmer and some blankets. That factor of the personal touch, for them to have somebody to pick up the phone, even call and spend 5 minutes on the phone with, keeps them from going to the emergency room. And that's the factor that really you can't see and you can't put numbers on. Just having that personal touch and being able to meet those everyday needs. You need some clothing. You need to be able to contact your family, and providing that cell phone and being able to call those that need support from their family that haven't been able to talk with them in months, especially during the pandemic. At the beginning, it was extremely difficult. They actually figured out a way to go drop food boxes off to our clients to help them have food in their home and feel secure, or in their tent, wherever they were living. And so just providing that extra boost was able to help keep them out of the emergency room. And that's really an add factor that we don't see. And don't talk about enough. So some success stories, obviously, through providers. We have providers that are working with us across the valley and continuing to build those relationships to help really remove that stigma from our clients and help them see what benefit they can have by working with the HUMS clients. It's been a huge success. Most recently, a couple of stories. We had a client that had been a longstanding client, actually had an addiction that turned into some individual medical issues as well. And by assisting with transportation and helping that client with their vehicle that they currently had, getting it repaired, they were able to remain 600 days sober. And actually are well over that at this point. They were also able to be accepted into the NIT Construction Safety Certification Program for 2021 and has been doing quite well. And so went from living in a tent and having sobriety issues to being successful for themselves and able to maintain and work with their own medical issues and maintain for themselves. We also recently just had a couple. They were out in the woods, living out in the woods. We had Christine, one of our community health workers, had moved them from a tent to somebody's backyard in a tent to now a shed. We're also waiting on long-term housing. The wife has been 9 months sober. The husband has been well over 12 months sober and also recently just gained employment. And so we're just waiting on some housing. And so it's a progression. It takes some time, but as you can see, some great stories that come out of this, and there's just many stories like that. Just providing a taxi, just providing a hotel room, a phone conversation can really affect and change those lives. So it's been a huge impact on the community, as well as assisting the hospital, and having partners like Massive Health Foundation, Mental Health Trust, the hospital. All have been a great addition, and excited to see how much further we can go. So with that, I am done.
Okay, well, I'm going to bring everybody back in on screen, and I'll also bring in Ralph. And we'll go ahead and start taking the questions. Ralph, did you want to start with anything?
Actually, I had a couple of clarifications on some of the data that Aaron presented. You mentioned that there was a 30% emergency department reduction. Was that 30% for the 100 patients or 30% of the total budget? The emergency.
30% for the demographic of the patients, for the 111 patients. Over that entire year, we had about 400 patients total. And so I would have to go back and pull that number for you, but that was for Q4 for those individuals.
So the patients, so you said you had 400 patients total, you're doing about 100 at a time. So what's the turnover in your, that implies each quarter you have a different 100 patients?
No, that would be patients that, so throughout the life of the span of the programs, what happens is and great question, let me explain how it kind of processes. So total, let's take for right now, we have about 135 patients total. We have about 69, what we would say are active patients. And out of those 69 patients, we have about 45 that we're actively working with. And so what happens is with most programs in areas like this, you will see where patients come and go. So what we do is end up considering a certain amount basically inactive because they haven't had contact with us. And so our community health workers would present and try to touch base with them a certain amount of times throughout the month. And if they're not willing to continue in the program, we just move them to a list that does not show we're currently they're not actively participating in the program, even though they're enrolled. So at any point in time in the program, we allow them to come back in without reapplying. They were already part of the program. And let me back up as well. And I think Ray may have mentioned this, that the only criteria for the program is 5 or more visits to the ED in the previous 12 months, and they must be 18 or older. So once they get enrolled into the program, they're in the program. Even if we considered them a success story and they're not using us for the last 6 months to a year, and they have something that happens after that year, they can immediately come back to us and say, hey, this is where I'm at and I need to be active again. Can you please help me? So we can keep those clients on a rolling basis. So when the data is pulled, it's for those active clients that have actually had services rendered through our database, whether you see it through Collective Medical or through Salesforce, and you can see that there's notes and information from our community health workers with those patients.
Just sort of clarifying questions. Does the demographics of your MIPS approximately represent the demographics in Matsu?
My Zoom cut out. Can you ask that one more time?
It said your demographics were 77% Caucasian, overwhelmingly, obviously. Does that approximately represent the demographics of the Matsu?
Yeah. I mean, we're working in Matsu only. So yeah, that's for that quarter now. Now that was for a quarter. So obviously those change, but I would say that still, as you look back through the data, it's still Caucasian still in the higher percentage right now. And so obviously that can fluctuate from quarter to quarter, but a lot of it stays pretty average.
Well, I mean, obviously with the 100 or 60 active patients, the variability is pretty high. I actually want to bring in something, I believe it was a presentation I saw, or a summary of the presentation by Elizabeth Ripley, that said many of these patients already had multiple caseworkers assigned to them, that various programs. And so we're adding a different kind of worker, but I'm trying to understand that situation, particularly where you've got 80% Medicaid. So I'm guessing some of those are case managers at Medicaid. And you mentioned the connection with the 1115 waiver, but I'm trying to understand that bigger. The idea of connecting people to some sort of services is obviously not a new piece.
Sure.
And so how does that, how was what was before connected to what's now? And perhaps also touch on the 1115 waiver in terms of where it might take you. Okay.
So I would say that, and let me break it down a little further, great question again, is that through our community health workers, they are not, you could consider them a case manager in a way, but what happens is once they enroll them into the program, the community health worker creates a set of goals, okay? And so if these people weren't connected to providers before, or they were currently, but they weren't getting to those providers because of lack of transportation or health issues or whatever it might be, not being able to keep up on their prescriptions, those goals could be set out with the community health workers as they work with that patient and say, okay, so you already had some of these providers lined out, but you're not attending these providers because you can't for whatever reason. And so they might line up a goal with that patient saying, okay, we're going to make sure you have transportation to get to this, and this appointment. And then we're going to make sure you have your monthly prescriptions refilled, whether we go get them for you and bring them to you or get you transportation to get those filled. So they have goals lined out. So it's not creating extra work. It's creating work to allow them to get to where they need to be to continue to stay healthy and not utilize the ED. So they come alongside them and provide the services that those other providers don't provide, the taxi services, the housing, the cell phone stability to be able to contact people and those sorts of things to be able to connect with those providers. So we're not creating we're not creating more added work for this client. We're trying to help the client through the work that is already needed that they were trying to do or that they didn't have to begin with. And as far as 1115 waiver right now, we're looking at a behavioral health, the behavioral area. We haven't even come close to starting this yet for HUMS, but we are looking at a scope of work, working with somebody to see how that would benefit to bring sustainability to the program. To not lean so heavy on the grant side, but to look at expanding, having not only grants, but the waivers through Medicaid to be able to make the program continue to be more sustainable long term.
But just to follow up, I was under the impression that Medicaid in Alaska, as well as in other states, have used case managers for, I'm not sure if they use the high utilizer name or not, but I was under the impression that the state was going, taxi is a good example. Transportation is paid for by Medicaid. Some transportation is paid for by Medicaid. And I appreciate that there are always holes that occur in these systems, but I had been under the impression that the state was at least doing this in, whether they were demonstration projects or whatever, but so how this links into what the efforts are elsewhere is kind of my, or what's been thought of is this idea of providing other services in an integrated way has been discussed. And again, perhaps I misunderstood, but I thought there were programs that were actually trying to deliver that already in Alaska.
Well, I can just give you the perspective of a frontline emergency physician of over a decade, who's also the medical director of a department and the vice president of the Alaska chapter of the American College of Emergency Physicians. I have never once in my career had a Medicaid caseworker ever reach out to me in any of those roles about a patient that was coming to the emergency department frequently. I've never had them, anyone try to coordinate on that level with me. And so what I would say is if those programs are happening very practically, they're not touching or reaching the emergency departments in a meaningful way. And I would agree with what Aaron said earlier. There are sometimes, prior to this program, there were programs in the community touching different aspects of people's needs, but they were very siloed and they weren't communicating, and there were massive holes. I mean, for a while, I've worked in many hospitals where you have an ER social worker, and unfortunately, we don't even have one right now. But their help would stop very quickly. They couldn't, they might be able to get someone a Medicaid cab voucher or something occasionally, but the problem in the valley is there's not that many cabs, and the transportation costs. I mean, try getting a cab to Talkeetna, that's like a $300 venture. And so if those programs exist, practically speaking, as an emergency department, provider, we're not aware of them, and they're not helping every day with patients. So that there really were those gaps, and that was a lot of the problem is that those programs were operating siloed off. They weren't communicating with us in the emergency department. So yes, I would agree that there are some of those things out there, but this program has helped to connect and bring them together. I can't speak specifically. I know our social workers in the hospital, we don't have ED focused ones now, but they struggle trying to get transportation ever. And I think occasionally they're able to get Medicaid to pay for it, but I know it was eating up a significant amount of the hospital's money. It wasn't getting paid for by Medicare or Medicaid. So if those programs are existing, they're not practically working, at least from our perspective in the emergency department. So,
and just to follow up on that a little bit, the Medicaid, Medicaid of course monitors, usage, and will oftentimes bring a halt or direct because of the overuse of Medicaid. Will kind of direct the care for the patient, but it's really based on a telephonic intervention and a, kind of under the idea that you can coordinate care telephonically with the patient. And we know that that's not completely, that's not what everybody needs. And we have also invited Optum early on to learn about our program and to also compare it to some of the telephonic follow-up interventions that Optum does as well, of course, as the administrator for the Medicaid program for behavioral health. So there is this idea that you can be efficient if you just use the telephone, you can reach more people. And I think that we have discovered that it's really more of the coming by and picking you up and taking you to the pharmacy to interact with the pharmacy tech to get your prescription, take it back home, lay the medication out, put it in a pill, all of kind of those things of walking people through those life skills that oftentimes a Medicaid budget won't provide to transportation if it's not for a treatment activity or an intervention or directly back home from the emergency department. But I would defer obviously to Tom's experience in the emergency department as to the Medicaid intervention when it comes to high utilizers with that. So we are, Optum actually has a seat on the MDT as well. So we have reached out to them to make sure that we are working in a complementary way to the goals that Optum has set out for high utilizers.
Okay, we've got some other questions queued up in chat, and Dan Sadler has his hand raised. So Dan, go ahead and open your mic and ask your question.
Thank you, Juanetta. Doctor, it's a fascinating presentation. I had the Health and Social Services budget and House Finance, and we had many discussions about what the term was frequent flyers. And so much as I want to ask questions about the philosophical, how do people get in that situation, I think you are doing a good job of actually dealing with the facts on the ground and the patients that present to you. My question is this: I heard the citation of about $4.7 million in savings. I know that the Prov and Regional and AMC have somewhat similar programs. My question is this: you at Master Regional have been able to provide cost savings with your HUMS program. Is this scalable down to what size? I mean, could this work for Soldotna or for Talkeetna, or not Talkeetna, but how far down the scale of size of populations you serve might your model work, still helping people and still saving costs for the healthcare providers?
I could jump in. I think really even a very small community, any community that's big enough to support an emergency department, I think that you could see cost savings. You will find, I would definitely go out on a limb and say in every community, you're going to find high utilizers for a variety of reasons. And I think that's just easy money on the table to save from a financial standpoint. And then the cool thing in addition to that is you're making meaningful difference in individuals' lives because you're addressing those systems failures. I will say there is not really any other program in the state that is operating in this way. Anchorage has a community paramedic program, but it's very different. They're basically paramedics showing up and offering some services on scene to try to get people from coming in, but they're not providing this full wraparound care. And I've had a different hat I wear is I'm the vice president of our professional society in the state. And so that's something I've had a lot of discussion with other providers throughout the state, and they're very interested in trying to figure out how to do, but there is not another program that's providing this level of wraparound services for this specific population in the state. And I am absolutely convinced from our experience that this would be cost effective and very helpful for any community that is big enough to support an emergency department, because every community is going to have high utilizers for kind of the same problems. I mean, I've worked in multiple states. I've been in medical training and in the medical system for close to 15 years now. And it's a phenomenon that happens everywhere. So I'm convinced that it would be a benefit everywhere. It's just probably a matter of convincing people to set it up and fund it to start with.
I think also, Tom, that that the kind of the essential elements, I think, are really not, or are really kind of rooted in having people in the system and people in the community that run these providers that are willing to get together and talk about how they can communicate better together for this ongoing care of patients and the care coordination. As you can see, by the last 45 minutes to an hour here, this isn't rocket science, so to speak. It is people helping people and being there kind of when they're needed to be there, and to walk with people through the very basic things that will help them to become better, and to have kind of the long view in mind about human behavior. we establish patterns early on, and they're really hard. Habits are really hard to break, but over time, you will see that, I think Aaron had mentioned, the longer patients are in the HUMS program getting these connective services, that their decrease in the use of the emergency department grows exponentially. It can grow to, what is that, 51%, Aaron, on that? And that is
Yes.
a huge phenomenon. But the time it took for that change to happen is what I think we really have to kind of respect, and to be able to kind of endure that with the patient. But if you have a system that works, and you have a medical facility, you have law enforcement, and you have a community of one or more providers of services, how do you meaningfully connect those two things? And that would be the question I would ask, and going into any other community, that would be the number one thing first, is those champions that want things to change in the system to help people better.
Great. And Dan had an earlier question that he submitted through chat, and if somebody could address this, is do you know how many HUMS clients may be veterans, and is there anything complementary, or is there an alignment with the VA medical system and what you're doing in the MATSU?
You want me to answer that, Dr. Quimby, or do you want to?
Yeah, you might be able to answer the number. I will say, yes, we do have a number of clients that are veterans, and that's part of that individualized, customized care, is that the community health worker will, reach out and engage with those resources, and the VA, as well as the ANMC system, who they both tend to have more opportunities for actual case management. So, a lot of these clients will have case management through ANMC, or sometimes through the VA, which other clients don't have usually. I mean, there's not other things for other people that don't fit in those systems usually. That the community health worker will work with them individually, and on occasion, as medical director, I've reached out to those caseworkers or providers that are part of that care plan to address specific needs. So we definitely do try to use whatever existing resources, whatever that the client has, as much as possible. But Aaron could probably, I don't know if we have that statistic or not.
Yeah, I don't have the statistics of veterans on here. That is something we need to look at. I don't know if Ray has seen that in other data from SSI or not, but I do know we have veterans in the program, because obviously I've seen them work with them as well as with the VA. And then also with our program here, our Veterans Directed Care program, we have had veterans that actually are wanting to remain in their home that are part of our VDC program, but also have been a HUMS client. And I've been able to watch both of our programs come together to help that client successfully, not only to remain in their home, but to help them with every medical need or transportation need they have. So I know we do have them. I would have to look to see if I can find that number for you, though.
So would it be safe to say that there isn't a current representative on the MDT that represents the VA health system?
No, not currently. No.
Okay. All right. I'm going to take one more from the chat, and then we'll bounce to Preston for a live question. Tom Shard is online with us, and he's actually submitted a number of things in chat. Tom, thank you so much. He's asking, in the sense that that HUMS is a gatekeeper model, how do you safeguard about misdirecting people who do need ER services? What's the backstop to make sure that there isn't a misdirect on that? And if someone,
that was my number one concern initially starting the program, and then also obviously it bears some liability now if someone who needs to go doesn't go. So I was under this misimpression that it'd be impossible to tell people when they shouldn't go. And yes, that is something that we regularly talk with the case or the community workers about, is that we never want to tell someone that they should not go to the emergency department when they should. And some of these people, it's very difficult. They have, very serious underlying chronic illness. Sometimes they are at the end of their life, and they are appropriately going to the emergency department really frequently. I mean, people who have end-stage COPD, for instance, they're going to have worse and worse attacks, and they're going to end up on oxygen, and eventually they're going to die from that. And the same with liver disease. So Yes, that was initially a huge concern. We've absolutely drilled this into the community health workers. And as of yet, to our knowledge, there's never been an instance where someone, was talked out of going when they were supposed to. So that really ended up not being a huge concern. There are, a number of people, we are not going to get their visits down to zero because they need to be going some. But in most cases, there are times where there's something else we can do to meet those needs. I mean, yes, if you have really bad history of coronary artery disease and have 10 stents and have had a bypass, when you have significant chest pain, you're going to have to go to the emergency department every single time. But if there's an anxiety component with that, and we can set you up with a counselor, or we can facilitate more frequent visits with your cardiologist, a lot of times we saw those visits come down. But yeah, that's number one mantra to the program. If there's any concern that there's an actual medical emergency, then those people, are not going to be barred from going to the emergency department in any case. And so, yeah, I had really wondered initially, like, were we even going to be able to reduce things because we didn't want to tell someone not to go when we did. But we found it almost, even the really complex chronic medical people, it was fascinating how even a lot of them, by connecting them with the right resources, they just didn't need to go as much. And when they need to go, it was more likely it was going to be an appropriate visit. So, but yeah, it's a good point. That's a huge concern of ours. So.
Okay, I'm going to bring Preston in for a question. And before he opens his mic to do that, I just want to say you've mentioned 3 community health workers or the addition to the program. Are there any other occupations that are additive to the program to make it work?
So
Aaron?
currently we have the program director, who we're actually in the middle of interviews for at this time. So you have the program director, and then you have 3 community health workers that report to the program director. And so that's all that's included in the program at this time.
Okay, all right, Preston, go ahead.
Hi, Preston Simmons from Providence. Thanks for presenting this morning. Excellent program and great outcomes, making a difference in the community. As you've gone through this, kind of what service gaps are you seeing out there? You have a high number of patients that have behavioral health, substance abuse, polychronic conditions, comorbidities, those type of things. What, if you were able to build additional services or support out there that would eliminate some of the gaps, what would those be? And then kind of secondarily, what are the policy gaps that exist that would also help? So down in Washington State, for example, you're able to do that field triage with the ride-along services and so forth that really connects a lot of the dots in the community to take care of these type of patients, better outcomes at a lower cost.
I can start very specifically to services. The number one thing, just as just for me and from my experience in the department, we really are lacking in resources for alcoholism. It's really unfortunate. I mean, I saw Dr. Zink post like just this week on her professional page that we have like the highest number of end-stage liver disease death in the country, and huge problems with alcoholism. I'm really happy in the last decade of practice as an emergency physician to see us go from offering nothing to people with opioid disorder to just overwhelming services and support now. And that's been amazing. It's wonderful. It's needed. But I have not seen a concurrent increase in services for alcoholism. And as we saw from the data, I mean, those are some of the people that still make up a large percentage of these high utilizers. And I just, as a practicing emergency physician, I don't have any way to get people into real-time detox or rehab. It's very difficult. And so for me, just, as a practicing emergency physician and program director, I'd love to see more resources for that. And then policy-wise, I would love to see this get adopted on a broader scale. And I would like to see the state, consider the state Medicaid, this idea that Washington, as I understand it, has enacted where if you are a high utilizer using Medicaid, that there's some teeth behind it to say that you need to participate in the program. Otherwise, you'll have some restrictions on your Medicaid. I think we're missing a lot of people who could benefit from this because they won't voluntarily enroll in it. But I think once that they were in it, they would, potentially get some benefit from that. And I guess maybe the other thing would be, it'd be really cool to have a crisis now system for this behavioral health, and that's happening. Where we're going to have the, hopefully soon, the call center, and then the mobile teams, and then a crisis center. So I think that would be tremendously helpful for mental health. So those would be my 3 answers.
And I think we have our work cut out for us with the emergence of the Crisis Now program here in Mat-Su. But we've had the benefit, though, of having Aaron and Dr. Quimby in on the planning for the implementation of Crisis Now services in Mat-Su. So we have, built the HUMS program, we've built the MDT, we have Connect Mat-Su, which is our pretty robust information referral project that we have ongoing here in the Mat-Su Health Foundation, and to glue those parts of the system together to help support the mobile crisis teams and help to support crisis stabilization is going to be really key. In fact, we've formed a work group that now is looking at, okay, now that the crisis is over, how do we support patients so they don't cycle back into the crisis services again? So in creating a Crisis Now high utilizer group, so how do we get them effectively spun off and supported at the same time with an immediate walk-in behavioral health service or continued peer support throughout the next 48, 72 hours post-crisis. So a lot of the changes in statute that have happened or are considered right now are going to really help advance that Crisis Now into being able to effectively have a program for involuntary holds as well through the crisis system. So we've got our work cut out for us, but it's really, really good work because we're very rich in having people in Mat-Su and across the state, especially with the support of the Mental Health Trust, to really move these initiatives forward in a meaningful and as planful way as possible. I think, though, the single service, to answer your original question, Preston, I think the single service that makes the most difference that I've heard, and Aaron can expound on that, is that of an emergency placement in a bed for people coming out of the emergency department, or even perhaps coming out of the DET beds on the 3rd floor of the Mat-Su Regional Medical Center. We have been transporting people into Anchorage for shelter placement from some of those programs. And we really need to seriously look at maybe not a mass shelter necessarily, but do we have temporary housing providers who could use 2 of their beds for these specific placements so that there's the best opportunity for a patient to get rested, to get clothed, to get cleaned, to get fed, to then participate in post-crisis services from that launch point. And we just don't have that at this particular time. Aaron, I'm sure you've got a myriad of things too on your wish list that could be seen.
I'm not going to jump on the soapbox, but I'm just going to echo what Ray was saying. I really think on the non-medical side, a bed is our biggest issue to be able to get them stable. Yeah, we can provide tents and try to stabilize them as best we can, but it's still just not. We need the roof over the head as much as possible. And of course, the state's been recently given some money in regards to try to do a 90-day service with a certain amount of money for some of these shelters, and they're working on that right now, but the beds still aren't there. And so it's not doing us any good. And so I'm a little frustrated with that area. And I think that we could help so much more, as Ray said, if we could just provide those simple things. It would probably change the speed and the trajectory of how we're able to service the patients and help them through that. So.
Thank you.
Great. Let me bring in Elizabeth. Oh, did you have a follow-up, Preston?
I did not. I just said thank you.
Okay. All right. Thanks. I'm going to bring in Elizabeth. Elizabeth, go ahead.
Yes, thank you, Annetta. First of all, I just want to really commend Aaron and Dr. Quimby and Ray As you can see, it's quite a collaborative community effort, and just the personal and professional investment that they've made to make this a success is extraordinary. But I want to tag on to a couple things that they raised up. One, Aaron and Ray just talked about housing and homelessness, and at Connect Mat-Su, our number one challenge that's being surfaced in this information referral hub is around housing and homelessness. Over 60% of the people that are coming into Connect Mat-Su are struggling with those issues. So, and that has its own policy level. I mean, there's a reason we're in this position around housing and homelessness. And so there's definitely some policy things that we could do to address that, but that's going to be an ongoing challenge for our community. It's not just a challenge for Mat-Su, it's a challenge for Alaska, it's a challenge nationwide. And so I just want to acknowledge that, because our policies feed into this homelessness and housing challenge. I also want to tag on to what Dr. Quimby said in terms of alcohol. The diseases of despair are hurting our country, and alcohol is that top one. And they, in some respects, disproportionately affect the white male population across the nation. And so, what are we doing upstream to address this feeling of hopelessness that people are experiencing, and putting those pieces in place, upstream. And the reason I bring that out is because, and I haven't looked at the latest data, gentlemen, so if you have more recent data, but the last few times I've testified, over the course of from 2013, from what Ray shared with you at the beginning, to the last set of data I saw, which was probably 2019, the number of super utilizers in our emergency department has only grown. So despite this program and this robust program, the number of super utilizers has continued to accelerate in our emergency department. I do not believe that we're unique. And that means these diseases of despair are feeding our emergency department, essentially, and all emergency departments. And so I also just want to point that out, that, whereas, Aaron, under Aaron's leadership, Lynx has done a good job to increase the number of folks we've been able to serve. We can keep building this program. I mean, we could, but if we could staff it, we have more super utilizers. Like, we have as many super utilizers really as we can serve. It's my understanding, without that mandate, without that incentive that Dr. Quimby talked about, right? So if you have some kind of incentive with the state, with Medicaid, the programs this program needs to be a lot bigger to serve those folks. I just also want to point out there's a disincentive for the hospital to participate. So it's not just about incentives to move folks and kind of compel them to participate, because right now it's voluntary, but there's a disincentive for our hospital because, as you can see, most of the patients are Medicaid and our hospital is getting paid for them. And so there has that, all of those things have to be aligned, including the disincentive for the hospital and the incentive for the folks who need these really low tech, low cost, as Aaron pointed out, interventions, low tech, low cost, and then we designed this program to be, and Ray, you can correct me, 3 years, and I know that Aaron and Ray and everybody are taking steps to see how we can work with payers to support it, but we shouldn't even have to prove this program works. I mean, that's why we have an external evaluator. We're copying things that have worked in other states. We need to be implementing these things across the state of Alaska. We don't need to experiment anymore. We have a model. Sure, it has to be tweaked to be regionally appropriate, but this is where government needs to act. That's all. I just like to say that. And I just really, again, commend Dr. Quimby and Ray and Aaron for this work. It's remarkable. And the wonderful team that's actually on the ground, literally on the ground, as Aaron explained, working with these individuals and giving them hope for a better life. That's just extraordinary.
Wonderful.
Elizabeth, thank you. I do want to clarify, there's a disincentive specifically for the hospital CFO to participate, not the rank and file staff, but I didn't realize that until I was in a meeting. At one point, we were throwing around these cost savings because everyone in the emergency department, this is amazing, we're saving all these people. But yes, there's a disincentive for the CFO and probably the corporation. Yeah.
We have a question in chat. Thank you, Elizabeth, and everyone. We have a question in chat again from Tom Shard asking how this program, how HUMS is different from the state's Medicaid Care Coordination Initiative. Anybody?
I can just say I've never interfaced with that program. I'm not aware of it. So I'm not aware that my other colleagues in emergency medicine are. So whatever they're doing, they're not talking to, in real time to people in the emergency department. So I don't know, maybe they're doing some behind the scenes things, but we didn't talk a lot about the way a lot of enrollment happens in the program. Is all of my physicians that work with me, as well as nursing staff, we try to empower everybody in the emergency department to be aware of the program, to have the number, which is like 887 HUMS. And then we at any point can engage with the patient who we're seeing come to the emergency department frequently, is not getting the services they need, and say, here's this program, would you be interested? And then immediately communicate with a community health worker. At different times, we've had coverage even until late at night. And then that person prior to COVID would come to the emergency department to enroll them, or if the patient was already enrolled, would be able to sometimes, take that call, start engaging with the client. If there's a Medicaid program out there, they don't do that. So the emergency department staff doesn't know about it. I can't call them in real time and get information or get them to come help. So I would say I'm just not aware of it. So I don't know what they're doing.
So I would add, and obviously I'm newer to Alaska, if you can't tell by the accent, but what little I do know about that program, I think it comes back to what Ray and I always talk about is the it factor for HUMS, and what Dr. Quimby just mentioned. We have the immediate contact. I think there's a distance there between that program and their clients. They're not going into their home and filling their prescription bottles and teaching them how to take their prescriptions and doing those one-on-one things. So I think that program has its place, obviously, just like any program. I mean, there's always a niche there for each program, but I think that we're going deeper with the client than probably what that program does. Again, I don't know as much about that program, but that would be my guess, is that we're able to have immediate interaction with them and create a plan for that patient pretty quickly. So I don't, Ray, if you have more or know more about it.
Oh, I understand that AMCCI, and I'm not care coordination initiative through Medicaid, and I think that is then kind of implemented through the Qualis administration of those dollars, I believe. I think there is a difference probably between the use of the word navigation and helping people to navigate the system, and actually providing the support service that it takes to alongside the navigation. And I believe that might be the difference between those two things. So again, we have had some communication and some previous working relationship with Qualis that is kind of ongoing at this point, as we explore through some technical assistance the ability, the potential to use and build for some of these services under the 1115 waiver, or under some crisis type of expenditures that might be appropriate for us. So we're currently undergoing that study right now, and I think within a month or two we will have a fairly clear roadmap as to what might be the first step toward that Medicaid billing along the pathway of at least substantial sustainability or partial sustainability of these services.
Great. Well, we're coming up on 9:27. Elizabeth, I'll go ahead and give you one last shot here. Go ahead.
Thanks. I just wanted to share one thing, and maybe it is a good way to close this out. I know that Preston Simmons and Providence are hosting a thing on the quadruple aim on Friday. And the first time that I met Dr. Quimby, and he was telling me about his journey to becoming medical director for this program, the HUMS program, he said, in fact, I like coming to work better now. and we talked about it, and it was quite remarkable. And that's the fourth aim that was added, which is happier clinicians and providers and more fulfilled. And this project really ties together, I think, the quadruple aim. It's better health for populations, it's happier providers, it's lowering the per capita cost of healthcare, because if we were able to implement this, we clearly have demonstrated that it's cost effective. And it's better care at the point of care, right? Because folks are actually getting what they need. So I just kind of wanted to point that out, that it's possible to actually achieve the quadruple aim. And this project, with the kind of leadership that we've had, is exactly how we get to those objectives.
Great. Thank you so much. All right. Well, again, we're coming up on 9:30, and I apologize for not getting to everything in the chat. There's some additional information in there. Lisa Keno is with us this morning. She's mentioning that Catholic Social Services has some services for veterans, and also the need for respite beds, and also some questions about what's the national model, how does this align, and what's the scalability of HUMS? And we've heard some discussion of that, but I think that's probably worth some future discussion as well. Ralph, I'll just go ahead and do a couple of commercials. We do have next on April 14th, we have the Division of Behavioral Health will be with us to talk about the 1115 waiver. And then I believe on the 28th, we will have the trust with the Crisis Now model. So we will be exploring some of the issues that have been touched on today a little bit further in future sessions. And we have an invitation out to CMS with their financial modeling group to come in and talk about alignment of payment systems, which has also been touched on today. So there's plenty of topics here, but I'm going to turn it to Ralph for any closing comments, and we'll go to you, Ralph.
Well, I just want to thank the three participants for joining us today and explaining what's been going on with this program. I think, as Netta indicated, that we're trying to bring in programs within the state, like the 1115 waiver, and make people both aware of what's going on, but also how these programs are interconnected, or perhaps where they need to be connected more in terms of the direction that we're going. So I very much appreciate the contributions today, and we look forward to continuing this discussion over the next few months. So thank you very much.
Thanks, everybody.
Thank you.